Good morning, afternoon, or evening, wherever in the world you may be. Welcome to the MIT System Design and Management Program's Systems Thinking webinar series. My name is Lois Slavin. I am the Communications Director for SDM. And before we start today's webinar, which we're really excited about, by the way, I wanted to apprise those of you who are going to be in the Cambridge area on Friday of an in-person presentation that will be made on wearables, big data, and healthcare innovation. It will be presented by MIT alumnus, double alumnus, master's and PhD in ECS, Todd P. Coleman. It will be from 11 to noon in Wong Auditorium, again this Friday. Check the SDM website at sdm.mit.edu for more details. I'd like to welcome today Dr. David Hartzband. He's been a very popular webinar speaker over the years, and we are delighted to have him with us. He will be speaking on Hadoop-Based data exploration for the healthcare safety net, technical and socio-cultural challenges to big data usability. Just a reminder to those of you who have attended webinars before and those of you who have not will be interested in knowing that the slides and the recording will be made available by the end of the week, and a link will be sent to all registrants. We will have a Q&A at the end of the discussion, and if any questions arise for you during what may be a very interesting and even controversial presentation, please type them directly into the chat section addressed to everyone. And with that, I turn it over to Dr. David Hartzband.
Thanks, Lois. I'm David Hartzband, and I'm here at the Socio-Technical Systems Research Center at MIT. And what I want to talk about this morning, I talked about this project in a previous webinar. It is a project, I need to say, that is sponsored by the RCHN Community Health Foundation. And the idea of the project is to deploy Hadoop-based analytics stacks into healthcare organizations that are federally qualified health centers. And we then work with the executives and the IT staffs of those organizations so the centers can use this type of analysis as a strategic decision aid. And so what I want to do this morning is to briefly describe the project and then to go over some of the preliminary results that we're getting from the analysis. And I'm very, very interested in people's thoughts or reactions to those preliminary results. So there are two dimensions to this project. There's what I call a socio-organizational dimension, and there's a technical dimension. The socio-organizational dimension has to do with how data is used and seen within the organization. And I'd have to say that this project is being done at federally qualified health centers, but it could be done at any healthcare organization, or in fact at any organization. So the socio-organizational aspects of this, it's important to realize that the use of data, whether it's big data, little data, or whatever data, is not just an IT function. It has to be an integrated aspect of the organization's strategy. The analysis of data must be done in this strategic context, and thinking about data, what I call thinking about data as an asset. Once you start thinking about data as an asset rather than something that's on a disk somewhere or that your IT people deal with, that thinking has to really permeate all of the discussions that the organization has so that all decisions are at least in part data-driven decisions. And it's also important to realize that this is not just the data that the organization itself, in this case, federally qualified health centers, actually produce, but it's a whole range of data outside of the data that the health centers themselves produce. And technically, we're looking at the management of data as well as the acquisition, adoption of the tools that we use both to manage and analyze that data has to be looked at as a long-term function. It can be located in a variety of places, and in fact, each of the centers that we're working with locates this function in a different place. Some in IT, some in a separate analysis division, some directly under the executive staff. One of the health centers we're working with has a chief strategy officer, and the analysts work for that CSO, which is somewhat unique for health centers. So regardless of where the function is located, it has to be thought of as a long-term function. It has to have a strategic focus, and it has to be aligned with health centers' capabilities and strategies. Hadoop and big data right now are, I would say, still slightly on the upside of their hype cycle. But regardless of the external pressures, opinions, fads, or where something is in the hype cycle, this type of analysis and analysis in general has to be aligned with the health center capabilities and strategy. So let me talk a little bit about where we are with the project. We're currently actively working with 3 health centers. We've deployed an analytics stack at 2 of those 3 and have preliminary results from them. We've done work with the staffs at all 3 for the definition of the inquiry that we're doing and for the use of this capability. We're doing some very deep planning work at one center, and we're starting discussions with a primary care association. PCAs were formed by the same law that formed federally qualified health centers, and they are the state entity that provides guidance for federally qualified health centers. This PCA happens to have what's called a Health Center Controlled Network, or an HCCN, that consists of 24 separate health centers in their state. And we're just starting discussions with them about bringing this project there. So overall, we have 3 centers currently active, 45 sites, about 100,000 patients a year, somewhere around 5 to 6 million diagnoses a year with respect to those patients. 2 of the health centers are urban. Federally qualified health centers tend to be either urban or rural. The law is explicit with respect to those 2 types. Both of the urban centers have between 13 and 18 sites. One has about 25,000 patients a year and 200,000 encounters, that is medical visits a year. One has about 55,000 patients a year and about 450,000 encounters a year. The rural health center covers a much, much bigger area. In fact, the rural health center's coverage area is about twice the size of the state of Massachusetts. But in fact, even though it has 14 sites, it only has about 15,000 patients and less than 50,000 medical visits a year. Some of their sites have as little as 10 encounters a week. So in terms of our proposed approach with respect to the technology, we're doing preliminary characterization of data using existing reporting or business intelligence systems. Many of the health centers have BI systems already in place and are doing some form of conventional analysis. We can use this type of analysis to determine how much normalization might be needed, what some of the anomalies in the data are, although we have not done that at any of the sites yet. We've gone directly to the use of the analytics stack. We do use existing data extracts or data warehouses if they are available. We have found some very interesting data quality issues with these extracts and warehouses, and I'll talk about that a bit later. We are layering existing data into an open source analytics stack. It is actually the Cloudera open source distro, and I'll talk in a little bit of detail about that later. We did pick an open source distribution for the Hadoop capabilities. Obviously, open source is not free. There's a good deal of expense associated with it. There's just no licensing expense. We use MapReduce 2 in the form of Yarn to generate results, some through R, but mainly we're using HBase to give us a parallel table-based view of the data, and we're using Hive, or more recently Impala, to provide massively parallel SQL query into HBase. I should say that the way this is designed, no actual data leaves the organization's security perimeter, only results leave the perimeter. And we've been using Tableau a little bit. I have an academic license for Tableau to do visualization of raw data. So this is the stack. We have the Hadoop distributed file system obviously on the bottom, Yarn, which provides MapReduce 2. We're using Zookeeper to do synchronization and services. We use Hue to do cluster analysis, HBase, as I already said, and Impala to provide the query capabilities. We're using Swar to do search, and Tableau at the top of the stack. This more complicated slide, the only thing I really want to say about this slide is at these three health centers, we're using a single node deployment of Cloudera. And I think that's important because when we think about the use of Hadoop, we think about massively parallel deployments. And obviously for small organizations and for healthcare organizations like federally qualified health centers, they don't have the IT staffs, they don't have the resources to provide, nor do they actually need, as we'll see, massively parallel deployments. And so we chose to experiment with doing single node deployments. We use Ubuntu Linux. We use a virtual server configuration with the equivalent of a 4-core, 3 to 3.5 gigahertz processors, 16 gigs of memory, and 1 terabyte of attached storage. As we start to deploy for the Primary Care Association, we are going to use a 4-node Linux cluster, each node with 4 processors, with each node will have 4 cores, et cetera, 64 gigs of memory and 8 terabytes of attached storage. So you can see these aren't huge deployments. Hadoop works perfectly well under these conditions, and in fact, the optimized SQL works very, very well under these conditions. So you don't need to have thousands of servers in order to do a Hadoop deployment. The reason we chose Hadoop was not because of the data volumes, although I'm going to show you what the data volumes are, but because of the data variety. The volumes are modest. For one health center, they do a nightly extract to a report server and have about 250 gigs a year with 3 usable data years. Another of the urban centers does a nightly extract to a report server, which is network-based in the health center controlled network. They have a separate data warehouse, and 6 years of data. They actually have about 2 to 3 terabytes of data right now. The third urban center does a nightly extract to a remote repository that's run by their health center controlled network, and they have about 400 gigs of data a year. The rural center has read-only access to the database underlying its EHR, and they only have about 65 gigs of data a year. So the data volumes are modest. The data variety is not. So let me talk a little bit about the data variety before I start doing the results summary. Most people, when they think of the analysis of healthcare data, think primarily of the clinical data. This is the data that's primarily now managed, captured and managed in electronic health record or EHR systems. Some healthcare organizations have substantial amounts of this data. Kaiser, for instance, has about 9.5 million patient records over 15 years, 15 data years of records. That winds up, without the images, being about 40 petabytes of data. That's not a huge amount of data, but it's starting to get there. If we think that Google potentially has somewhere between 4 and 5 exabytes of data under management, healthcare data is not big data in that same sense. But in that data, we have the clinical data, we have demographic data, we have financial data, which, as you'll see in a minute, can be an issue. We have image data. We have data from other sources. We have population health data from states and from the federal government. We have state and federal demographic and census data. We have geolocational data. So we're starting to look at a very broad variety of data that we want to bring together and be able to analyze across all of those different types of data when we look at providing strategic analysis for decision-making in these kinds of organizations. So we've looked at the results now from a couple of these health centers, very preliminary results, and I'd have to say, initially what we did was we looked at some results from some strategic tables, and we made some assumptions about what we were going to look at after talking with the staffs at these health centers. And we decided to emphasize some of the demographic data and the diagnosis data that was present in those tables. And each of the health centers that we worked with wanted us to look and see if we could determine comorbidity clusters that were prevalent in their data. And obviously, the idea around determining comorbidity clusters, that would be a cluster such as the one we think of for something like metabolic syndrome, where we're looking at hypertension, type 2 diabetes, obesity, congestive heart failure, and some behavioral health diagnoses, or something simpler just like obesity and diabetes. So we wanted to look and see if these comorbidity clusters appeared in the health center data and how easily they could be identified. And we started looking at the data, and we started finding some, what I will call here, anomalies in the preliminary results. So this first category of issues I've called omission, commission, and migration. One of the things we found in one of the data sets was, if you look at, for instance, the diagnosis tables, which are associated with a patient and with an account, with a specific medical encounter, they have diagnosis codes associated with the patient and the encounter. These are the ICD-9 codes We're going to ICD-10 later this year, which is going to make this substantially more complicated. But today we're still using the ICD-9 codes. So in one instance, and ICD-9 codes are things like, they're numerical codes, and when you look in the data, there'll be a code like 250.91. And so you'll know 250 is the general code for the diagnosis of diabetes, and the 91 will be a specific diagnosis within the overall syndrome of diabetes. So we found a whole series of codes in this data that had multiple different descriptions. And while it's true that the Centers for Medicare and Medicaid, or CMS, do change ICD-9 codes annually, they never change the actual core diagnosis. So 250 is always going to be diabetes. And some of the codes around the edges might be added to, or the description might be slightly changed. So for one code in this data, we found 29 totally different descriptions associated with it. And so there were patients in this data set which had this diagnosis, but they represented 29 totally different diagnoses. Well, this isn't very helpful. When we went back and looked, the only thing we could really see in this data was this health center migrated their EHR at the end of 2011, and they moved from an EHR called MISIS to one called NextGen. And looking at the data before and after the migration, these kinds of errors, and there were many, many of them, it wasn't just this one code, appear to have been the result of the migration. With respect to omission errors, we found that many demographic and clinical fields are left blank for each encounter. So a provider, whether it's a physician's assistant or a nurse practitioner or a physician, will be working with a patient. They'll have the EHR up in front of them, and they will be filling out the EHR, but they will not fill out all of the data that's required to actually fill out the information for the encounter. So lots and lots of clinical fields and demographic fields left blank. And what this means is when you go back to look at the data, there's stuff that you just can't tell about that encounter. And in many cases, even what the diagnosis was. Then there were also clearly some very incorrect data that was entered. And the example I'll use here, although it's only one of many examples, is BMI. Now, BMI, we found ranges entered into these EHRs from 5 to 301,000. Now, the only comment I'll make is a 5-foot, 1-inch tall woman weighing 325 pounds has a BMI of just over 61. I have on the slide here, no one alive has a BMI of over 100, although I have been told as recently as this morning by one of the chief medical officers that I work with that they actually know of a couple of cases where people had BMIs of close to 100. That would be someone who was 5'10" and weighed around 620. No one has a BMI of 300,000. And so this is just clearly wrong. We found similar incorrect ranges for things like blood pressure and for static blood glucose. While it's possible to have a static blood glucose of over 200, you would be in substantial crisis if you were walking around. I believe that would be an HbA1c of somewhere around 24 or 25, and you would have substantial problems. So these are obviously errors. So I'll talk about interpretation in a few minutes, but these were some of the kinds of results that we saw overall. One of the things that is more systemic has to do with the non-alignment of clinical and financial data. Every health center that we've talked to, and in fact, every healthcare organization that I've talked to in the last 5 years or so, wants to do an analysis of the type, what do my highest utilization patients cost me? Looking at these comorbidity clusters, if these are my highest utilization patients, what does a patient who has type 2 diabetes, is morbidly obese, is hypertensive, and has congestive heart failure, what does this patient cost me? And let me look at this along a bunch of different dimensions. Well, once you start talking about cost, you're talking about financial data. You're no longer talking about the billing data that is part of the practice management system and of some EHR systems. You're talking about the actual financial data. And in all cases, financial data is entered, managed, and analyzed in different software systems. There currently are no EHR or practice management systems even used at the largest hospitals and largest healthcare organizations where they are the system of record for financial data. They are the system of record for clinical data and for patient demographic data, but not financial data. We also found that there's almost no technical link or only tenuous links between these two types of data. Financial data tends not to be organized by patient or clinical encounter, but rather summarized by things like location, time period, payer type. The link to patient and/or encounter can be inferred, but it's not direct, and it's very difficult to do in most cases. In all of the cases we've looked at so far, this is done by different staffs, and those staffs are not very aware of what the other staff does. The financial people are not very aware of the data that's in the EHR and the practice management system, and vice versa. We have one case at one of our urban health centers where the financial data appears to have an encounter key, and we're in the process of looking to see whether this encounter key actually matches something in the clinical data that we can use. Again, I'll talk about the implications of this misalignment later. Patient count discrepancies were something that I had not anticipated. We initially calculated patient counts at all centers as the number of unique patient IDs with an encounter with an associated diagnosis per year. So in other words, this is a unique patient. They came in at least once, saw a provider, and had a recorded diagnosis in the health record system. That was counted as a patient. If that patient came back 15 times, they weren't counted again because we already had that unique patient ID. In one case, for one of our urban health centers, using this method, we got 25,353 patients in one of their data years. And unanimously, the staff at that health center, including their chief medical officer, was of the opinion that that was way too high, that they didn't have that many patients. And so we asked them, well, how do you calculate patients? And the way they calculated patients was they took the number of unique patient IDs of patients with billable medical encounters, and I'll talk about that in a minute, that had an associated diagnosis per year, minus their dental patients that did not get their primary care at the health center. And they got a patient count of just over 19,000. So these are quite different counts, 19,000 and 25,000. So we then said, okay, well, there are kind of definitions. There's a definition for what's a billable encounter. So for instance, if you come in and you have a nursing visit, that's not a billable encounter, according to CMS. A lot of behavioral health visits are not billable encounters. Optometry visits are not billable encounters. A lot of medical counseling visits are not billable encounters, and they're also not considered medical. And so a substantial amount of encounters of patients were thrown out because they came in once or twice but didn't have billable medical encounters. This health center also has 4 sites that are only dental. And so they looked at the patients that they saw that were dental, and if they didn't have an assigned primary care provider at the health center, they figured that they were just getting their dental care there and they didn't count them. Well, we negotiated with them and they agreed to put some people back into their account, and they agreed that they had 21,054 patients in that data year. Still quite different than 25,000. So we went ahead and we actually calculated the diagnosis percentages and comorbidities using both numbers, and luckily the percentages were not significantly different. Again, I'll talk about the interpretation in a few minutes. So we come to cultural and training bias errors. We know that health center populations are not healthier than the US population as a whole. And so we went and we used the Center for Disease Control FastStat data for each data year that we had. And we used that to compare the percentages of diagnoses in the CHC data from the diagnoses tables. And what we found was that obesity and heart disease in the health center data were very substantially underdiagnosed. Somewhere around 4% of patients in the combined health center data were diagnosed as being obese, whereas in the US population for those data years it was around 35%. With respect to heart disease, there were very, very few diagnoses of heart disease in the CHC data, but for those data years, about 11% of the US population had diagnoses of heart disease, according to the Centers for Disease Control. So these are very substantially underdiagnosed. And even for hypertension, diabetes, and behavioral health issues, they were diagnosed only at about 2/3 of the rate that we find in the US population. And again, we know that for health center populations, this isn't the case. So let me talk briefly about some of the implications, and then I want to leave a fair amount of time for questions and debate and throwing things at each other, although there are only 4 of us in this room, so I don't think we're going to throw anything at each other here. Feel free to throw things at yourselves. So if we look at this first category of what I've called anomalies or data irregularities, the data in the case where we had the migration was bad enough that the data years 2009, 2010, and 2011 were just not usable. We could not make sense of the data, and we could not come up with an algorithm that would fix the data in some sense so that we could make sense of it. And so the first consequence was that we lost 3 data years. In another case where there was no migration, there were many fewer errors, and only 1 data year, 2009, was not usable. That was primarily because in that data year, for some reason, a lot of clinical data for each encounter just was not entered. In the case of incorrect data being entered, obviously, if an analysis is done using this incorrect data, it's not reflective of the actual population. Extreme values, like the ones we saw for BMI, blood pressure, and blood glucose, clearly skew the results and call into question how we can interpret those results. So these errors are problematic. There are ways of looking at the data where you can do filtering, where you can do some other types of normalization, and where you can potentially use some amount of this data. But clearly, even just in this small sample of 3 health centers, we had data years that were just not usable. With respect to the non-alignment of financial and clinical data, we're still exploring, first of all, whether we can infer patient and encounter information from the financial data at several of the health centers. That would be good if we could, but that would be probabilistic, and we would like to not have to make those kinds of inferences. If we can't actually make significant inferences, then analysis of cost per parameter, that is cost per diagnosis or cost per patient, cost per comorbidity cluster or location or provider, just isn't going to be possible. And that's very unfortunate, because that's one of the major things that all healthcare organizations not only want to know, but need to know. If you think, for instance, about new types of organizations, like accountable care organizations or ACOs, they are entirely based on a capitation rate per patient, what each patient costs. So this would be an unfortunate result for health centers. The third health center that we're looking at, as I said, appears to have an encounter key embedded in their financial data. We don't know yet how that encounter, it doesn't match with the encounter keys in the electronic health record data directly, but it may in fact match in some other way, and we're still exploring that. With respect to patient count, I would like to have a simple non-exclusionary algorithm for calculating patient counts that you could apply everywhere. The algorithm we used initially, unique patient ID with an encounter and a diagnosis during the data year, is such a definition. The algorithm that we uncovered for one of our urban centers was both complex and exclusionary, and really unique. It couldn't be used at the other centers, partially because they don't have the same kind of situation with dental patients. Some of them actually don't provide dental care. They don't agree on not counting only billable encounters, and many of the other health centers count some of their non-medical encounters with respect to patients. Things like nursing visits are counted as a medical encounter. Many screening visits, screening for hypertension, screening for diabetes, are counted as medical encounters. And so this algorithm that was so exclusionary really was unique and couldn't be used elsewhere. But if every center and if every healthcare organization has a unique way of defining patients, or in fact any other core term, when we talk about semantic normalization and we sit down with the health center staffs and we ask them, what is your definition of encounter? What is your definition of provider? What is your definition of service, of cost? I'm leaving outcome out because I actually was a part of an ONC committee that met for 3 days trying to find some consensus on standardization of outcomes. We actually agreed on the definition of one outcome during that period of time. And you will probably not be surprised to learn that it was morbidity. I'm not going to comment on that. But without this common definition, this semantic normalization, broader comparisons or broader aggregations of data are just simply not possible. Patient count's just the tip of the iceberg. If you're going to have different definitions for encounter or provider, one health center that we work with uses a definition of provider as anyone with an NPI number, but that doesn't work across the board. For instance, in the Commonwealth of Massachusetts, most nurses have an MPI number even if they're not advanced practice nurses. And that's not the case in other states. So right away, your definition of provider is not normalized. And then there's cost. What are we actually talking about with respect to cost? So these normalizations of definitions are both very important and very problematic. Underdiagnosis is also problematic, and I've spent a lot of time discussing this with people in the project, with the chief medical officers at each of the sites, as well as a lot of their other staff members. People talked about 3 types of causes. The first type is what I've called cultural and training biases. And everyone seems to feel that providers, especially doctors, are trained to treat what's in front of them. The example that one CMO used to me was, if I'm treating a foot infection, I might not even look at the problem list. I'm just treating that foot infection. That person might be a type 2 diabetic, and their foot infection might be exacerbated because of that. But I'm treating their foot infection, and I almost certainly will not list diabetes on the diagnosis for that encounter. I will list foot infection. Well, that's a problem. The same is true of most, if not all, of the comorbidities that we discussed. Then there are technical problems with the EHRs. Many EHRs, including several of the ones used by these health centers, have almost totally separate acute versus routine encounter workflows. If you're treating an acute condition, then you're looking just at that acute condition, and the EHR makes it difficult to create a record that is complete with respect to comorbidities. It's also true that many EHRs have ease of use issues that can cause providers not to fill in multiple diagnoses, and that many EHRs are not well aligned with the provider's workflow. And so at the point where they might be able to fill in additional diagnoses, they're doing something else. So there's certainly technical characteristics of the EHRs that don't help with this. And in fact, as several of the chief medical officers pointed out, play into the potential cultural and training biases of the providers. Finally, there's reimbursement models. Our current reimbursement models, particularly the CMS Medicaid reimbursement models for PPS, really don't encourage the reporting or treatment of comorbidities in the same encounter. With respect to PPS, if you have defined your treatment bundles in such a way that comorbidities are actually treated in the same encounter, then you would be able to do that. But most of the people that we've talked to have not. And so if you're in a PPS model, which health centers currently are, then you really are not going to be focusing on the comorbidities. in at least one case, one of our health centers, comorbidity analysis really just wasn't possible, as the underdiagnosis ensured that we didn't really have any comorbidity clusters. We knew that they were really inaccurate and not representative of the population. The CMO at that health center estimated that 20 to 25% of their patients were diabetic and about 35% were obese. But the only comorbidity cluster in the data found above 2% was obesity and hypertension. The chief medical officer's estimate was that this should have been around at a 35% level, but it actually occurred at a 2.4% level in their data. If this kind of irregularity is widespread in the health center data, which it may be given the consensus on causes, then this whole effort of comorbidity analysis based on diagnosis data in the electronic health record for cost control and clinical intervention gets called into question. It also has implications for how providers are trained, how EHRs are designed, and how care is reimbursed. We've begun to try and ameliorate this problem by doing direct analysis of the clinical data. In other words, if we're looking for the percentage of diabetics in a population, can we just look at blood glucose levels and HbA1cs? Again, you can do that, but in at least a couple of our cases, there were enough errors in this data that it made it difficult, or at least compromised what we thought of as the analysis. So I just want to say that I cannot emphasize strongly enough that these results are preliminary, that the kind of issues that we found in this preliminary analysis are just that. We're at a very early stage here. We have a lot more work planned, and we have a lot more health centers that we want to look at in order to see if these kinds of issues are generic. Obviously, if they are more widespread, then it looks like data quality problems in multi-year EHR records at health centers could result in some real problems in data analysis, and potentially may be the result of technical and usability problems with the electronic health record systems, sociocultural and training biases with providers, and in current reimbursement structures. So I'm going to stop here. I think we have 15 minutes or so, and Lois has been moderating the questions that have come up in chat. I'm going to try and answer as many of them as I can in 15 minutes. And I'm also going to say that I'm going to come back in 4 or 5 months, hopefully with a lot more data, and be able to talk less preliminarily, if I can make up a word, about what we've seen in that data. So stay tuned. And Lois, how are we doing on questions?
Well, first of all, David, that was a great presentation. Thank you. And we don't have any questions yet, so if anyone would like to ask a question, please type it directly into the chat section addressed to everyone. And sure enough, we have a question from Avikal Malik. Have you thought about using the lab data and not EMR for direct analysis to identify underdiagnoses?
Thank you, Avikal. Yes, we have thought about using that. Hopefully, at some point, lab data will be more integratable into these data sets. We're at the point with one of the health centers where we're taking, they have a separate kind of data store for their lab data, even though it's supposed to be going into their EHR. And we're looking at loading that data store into Hadoop, into HDFS, and then being able to look at that data across patient and encounters. The issue really is, and obviously it's a larger issue than just with lab data, but the issue with lab data and many other types of external data at this point is how integrated can that data be into the EHR. That's quite different with different EHRs. And even when we look at the lab data as a separate data set, there are some data quality issues with that lab data as well. So yes, we are going to be looking at that. As I said, we've only just started looking directly at the clinical data to try and see if we can pull some of the information out that we need rather than from the diagnosis tables. And the next thing after that would be looking at lab data, depending on how well integrated it is, how well integratable it is, or how available it is to us. And obviously this is an issue if you look at the federal emphasis this year on integration and the guidelines that they've just issued for integration and the 10-year HIT plan and the stage 3 meaningful use requirements. Integration is going to be a big deal.
All right, from Nathaniel Doku, what are the major causes of missing data in EHR systems?
Well, I wish I could tell you we know. I think that with respect to missing data, I think there are a couple of things that are working against us. And without pointing a finger at anyone, providers generally are the ones that enter data into electronic health record systems. There are some organizations where physician's assistants or some other staff member will do that after the fact, but at most health centers, providers enter data during the encounter. We know that this is problematic because the provider is sitting there with the patient in the room or in the cubicle trying to talk through an encounter workflow, trying to determine whether there is a problem, what that problem is, what brought them in to the health center, what needs to be done. And to create a complete record for each encounter, I think is very, very difficult in those kinds of circumstances, given that at some of the urban centers, that provider may be seeing many, many, many patients during the day and may have less than 20 minutes to actually complete an encounter, fill out the record, and then move on to the next patient. This is also clearly a problem, for instance, at large public hospitals. And so I think that's a problem. I think that the design of many EHR systems, as we've already talked about, there are ease of use issues, there are workflow alignment issues that make it difficult and also kind of drive the provider into not making a complete record. But again, I wish I knew what the exact causes were. Those are educated guesses.
Okay, just a note here, we have a slew of questions, and if Dr. Hartzband is amenable, we can go a little over 1 o'clock. This will be recorded, and also just a reminder, you will get a link to the recording and the slides and to Dr. Hartzband's email address. So if you'd like to follow up, those are some good ways to do that. From a PN who asks, is it a fair assessment to say that harmonizing structured and unstructured data sets is the most time-consuming element?
One of the reasons that we chose to use Hadoop clearly is that this really, I won't say, I'll say it simplifies the management and usage of structured and unstructured data. I came to MIT about 11 years ago, and before I came to MIT, I was a technology vice president at the EMC Corporation, where we did a lot with respect to storage of both structured and unstructured data. That's what I worked on. I guess I would have to say that Hadoop is probably the most interesting thing I've seen over this period of time with respect to how you deal with both structured and unstructured data, and the fact that you can do your normalizations, if they're necessary, as part of the query process makes it much more straightforward. So and this is what I said about variety earlier in the presentation. Most healthcare organizations don't have an exabyte of data, or even the 50 petabytes that Kaiser might have. But they have to deal with a broad variety of data, much of which is structured, some of which is unstructured, some of which is image, some of which is text, some of which is even less unstructured than that. But we're only just getting to the point, even with the Hadoop-based types analysis, where we're looking, in fact, I'm working with someone now where we're looking at text and speech recognition with respect to things like physician's notes, so that we can actually do searches into physician's notes and do a variety of other things. So yes, I think this complicates matters, but this really is the reason that I've moved the research I'm doing away from conventional data management, and that we're using Hadoop at this point.
Okay, from Carol, excuse me, Beismeyer. Carol, sorry if I mispronounced that. How will the conversion to the new medical billing codes affect the analysis you are doing?
Oh, Carol. I don't know, maybe you can come help us do the conversion at these health centers. ICD-10 goes into effect in October of this calendar year. I don't remember the exact count, but there's something like 5 times the number of codes in ICD-10 as there were in ICD-9. So I would, somewhat tongue-in-cheek, I think I'll say that it affects the analysis because it will make it both substantially more complicated if we're still at that point looking at treatment and diagnosis codes, and it will also mean that using Hadoop was a much better choice because there'll be substantially more diagnosis data. My personal opinion is that that October date is going to get moved again, but I'm not betting on it, but I think I'd be surprised if we don't get to September and the American Hospital Association and a whole bunch of other large lobbies start pounding on Congress. The date's already been moved once.
Okay, from Laura Monroe, have you mapped and defined workflows to better understand the data collection and analysis?
That's not my expertise particularly, although I've been working with healthcare organizations for quite a while now. I am working with someone, and we're starting to look at doing that given the kinds of issues we're seeing with the EHR stuff. Everyone we've talked to, mostly providers and the chief medical officers, are unhappy. Or I'll put it this way, I haven't talked to anyone yet who is extraordinarily delighted with the workflows provided by their EHR. Some of them seem better, some of them seem not better. And so obviously workflow alignment is a large question here, but it's been a large question since Meaningful Use Stage 1 and since even 10 or 12 or 15 years ago when people like Kaiser and Mayo started using their own EHR systems. This has always been an alignment issue, even in the EHRs that are developed by providers initially. So yes, I think that's one of the real issues. I think ease of use in EHRs is also a substantial issue. You know, and the kind of the compelling reason, if meaningful use is the only compelling reason to use an EHR, that's a problem. Obviously, the real compelling use is sharing of data and this type of larger scale analysis of data and making data easily available to different providers. Direct does that today, and without getting into the NWIN and all of the national architectures and all of the efforts that have been done to try and do data sharing in HIEs and data integration. So that's a much bigger topic, Laura.
Okay, and now we have a two-part question from, excuse me, Gagan Jain. One, if a patient's changed insurance, would they be provided separate unique IDs? And two, did you try a combination of diagnosis, drug, and lab, generally weak recording, to ascertain diagnosis? This is usually done in outcomes research.
Right, that's true. So those are both good questions. What we found is at each of these health centers has a different protocol for patients who change insurance, and that has happened quite a lot with, you know, with the advent of the Affordable Care Act, where people either got insurance, had insurance, lost it, and then got insurance through an exchange, or had insurance and that insurance had to be canceled, and then they got insurance through an exchange. So we've seen that a fair amount, and so at least the health centers that I'm working with, even though they may have different protocols, all of them have a protocol for determining whether they have records for that patient under a different ID and for merging those IDs. With respect to the combination analysis, I was trying to make clear somewhat before that we are beginning to do this type of analysis both with the clinical and the labs data, looking at the data directly to try and ascertain a diagnosis, as is done in outcomes research, and we're only just at the beginning of starting to do that.
Okay, and our final question from Naresh Verma. How does one get actively involved with this research?
Well, one way is you could get a hold of me and we could involve you. That would be a way. Well, you know, when the slides come out, my contact information is going to be on it. And Naresh, why don't you get a hold of me and we can talk about ways other than getting involved with what I'm doing. There are a lot of people doing research like this, not just here at the Institute, but across New England and all over the country, and Washington, with nonprofits, with a whole range of things. So we can talk about that offline if you get a hold of me.
Okay. David, thank you very much. This was awesome. Thank you everyone for attending. I'd like to remind those of you who are in the Cambridge area or will be on Friday that we have a special live speaker talking on wearables, big data, and healthcare innovation. Please go to the SDM website for details, sdm.mit.edu, and we welcome you to join us. We will resume the SDM webinar series in May, and you will be getting a notification as to what the details of that upcoming webinar, which will be presented by Professor Ollie DeVeck. Again, thank you all to coming. David, thank you so much for another great webinar.
Thank you. This was great. Thanks, everybody.
Have a great day.